All right, everybody, welcome. This is 2023 SLOEs Explained. I'm Robin Hoelle. Please feel free to ask questions, write them in the chat. Somebody will be monitoring the chat or just interrupt because there may be something that is important for me to talk about and important for you to learn about. Okay, so this slide I'm putting up, same slide. These are the QR codes for FCEP's Medical Student Council page on FCEP and their Instagram, which is where you guys can get all of your information about events to be involved with, what other students are doing across the state, and important news, and most importantly, I think, opportunities. So please go take a look at that. Future sessions, there's 4 more scheduled. The next one's going to be a month from now, actually. Strategies to choosing 4th year schedule. So take a look at these, and the slides of this presentation, along with the other presentations, will all be posted in and available to you in a folder of resources. So all of this will. This is my introduction slide. Again, I have been involved in emergency medicine education for a very long time. I was a community ER doc for a while, and I'm currently the program director for North Florida EM, but also very involved with FCEP, which is what brought me to you. I'm the Medical Student Council faculty chair, not as important as the student chair, but the faculty chair, and I'm here for you guys. I added this slide today. Emra and Cord put together a student advising guide, and this guide is basically, it was updated this year for 2023, and it has great information in it. So I put the QR code up if you guys want to peruse and take a look at that. All right. Before we talk about the SLOEs, I want to make sure that we're on the same page about your rotation. What you get by achieving your goals is not as important as what you become by achieving your goals. So Zig Ziglar, who was a hot mess himself, but had great quotes, said this, and I just put this in here to remind me to say, you are actually going to your audition rotation to learn about emergency medicine and experience what it's like and affect other people. Even though we're talking about the SLOE here, I don't want you guys to lose the experience of the gains of learning and growing on your rotation. So don't forget what we're doing this all for. It's not just getting a good SLOE, but I'm going to tell you about that. Okay. SLOEs Explained. We're going to talk about the what and whys of SLOEs, because there is more than one type. The meat and potatoes, what's communicated about you, and eSLOE frequently asked questions, so that we can get some of the questions you've already asked when you registered, we'll get those answered. All right, the what and whys of SLOEs. So basically, when I am presented with a narrative letter of recommendation, I want to Baker Act myself, and it's terrible. Narrative letters of recommendation don't communicate to me or to other PDs what we really want to know about you as a student interested in emergency medicine. And we're all emergency medicine people, so we have attention issues, and reading long letters is hard for us, and we just want to get to the bullet points. So narrative letters of recommendations really weren't the best way for us to get information on how you performed or how you experienced your rotations. And emergency medicine was actually one of the first specialties to institute and then do research on and revisit and improve upon the standard letter of evaluation. So in 1997, when you were a twinkle in somebody's eye, EM created the first standard letter of recommendation. They used to be called SLOEs. And they standardized a letter. So instead of all the writing, there were questions that you answered as a clerkship director. You answered about the student rotating. And most of it was basically, are they in the lower 1/3, the middle 1/3, or the top 1/3 of students? And in 2016, they converted it, the Cord converted the SLOE to an eSLOE. And that's really important because E stands for electronic. eSLOE was basically a website launch, and you, as a clerkship director, had to basically not register, but you had to form an account and be validated as an educator. And you were credentialed academic EM faculty, and you were allowed to write these letters. And this is also important because on the letter, the letters are on this website, and the website keeps track each year. So last year you had 24 students rotate, and this is how many you said were top 10%. This is how many you said were top 1/3, middle 1/3, and low 1/3. That's really, really important because some programs where basically everyone was top 10%, 100% of their students, and then some programs actually had a good distribution. So when I'm reading an evaluation from, let's say, California, and I don't know the people personally, like I know most people in Florida, and I can see that when they say this student is top 10%, and over the last 3 years, I think it is, I can't remember now, 0% of their students were ranked as top 10%. I know that that is for realsy. So all of these attempts were to legitimize and give good information. And all of this is good for you. In 2020, the OSLO, subspecialty SLOE, and the, it's not here, but the non-residency based SLOE debuted for other types of rotations than in the academic emergency medicine department. And we're going to talk about all of those. In 2022, the eSLOE was updated by the committee to match, you'll see some of the, instead of milestone based, it's entrustable based, and we'll look at that. That's 2023 is where you are now, and 2022 update is what you're going to deal with on your rotation. So let's take a look at that. There are 4 types of SLOE. This QR code takes you right to the CORD website that has a link to all 4 types of these SLOEs. And I'm just going to go through them, each one, what they are, very briefly. So the eSLOE is when people say, hey, you know, upload your SLOE to ARIS, we want to see a SLOE. That's what they're really talking about. This is written by faculty from an established EM residency program. We are going to address the fact that now it can be difficult to get a rotation in some circumstances, specifically with a place that has an EM residency. If you rotate somewhere, like you're assigned by your school and you're rotating somewhere that does not have an EM residency, they may have lots of students rotate there. They may have the expertise to write a SLOE and give good information and feedback. They will be filling out the non-residency based SLOE. And this is EM faculty without a residency, a home residency in their department. And I believe a lot of you guys are, your assigned EM rotation may be in this scenario. The subspecialty SLOE is if you use one of your electives to take, we offer, for example, an EMS rotation for medical students. We offer an ultrasound medical rotation for students, and we can fill out a subspecialty SLOE for you. There is also an OSLO. So the OSLO is an off-service SLOE. And the off-service SLOE is a document that you can request. Let's say you just crushed it in your, I don't know, surgery rotation. And you have a surgeon that's like, you're the best thing since sliced bread. I'd be honored to write you a recommendation. If possible, for sure, we would prefer that they fill out an OSLO, because the OSLO basically asks the questions we want to know the answer to. We don't care how awesomely you rounded, but we do care that you were on time and you were well prepared and you had these skills. So the OSLO leads the letter writer to the points that we think are important. And there are instructions on the website on how to invite them to write the OSLO appropriately. So I can take more questions about those now or when the time comes. And we have tornado warning. Okay, SLOEs explained, the meat and potatoes. What is communicated about me? So it is very, very advisable that all of you know exactly what's on the SLOE. It's better than you guys having someone write a narrative form about you. You know exactly what we're being asked and what our choices in answering are. So let's look at it. So there's 7 parts to the eSLOE. there's a demographic data, background data, like part A through E, and these are divided up into EM task competency, your personal attributes, how much guidance you will need in residency, how much guidance we predict that you'll need, written comments, and then institutional information that is about the like where you're rotating. And I'll take you through a SLOE now so you can see what that looks like. This is literally what this is the demographic data. This is part one. And this is what it looks like when we read a SLOE in your ARIS application, because the SLOEs are basically uploaded as PDFs, and this is the top part. So you'll see this is demographic data that basically will have your name, then it'll have what your evaluator institution is, and then you'll have the evaluator names. You'll notice that there's 3 names here. So this is really important, and everybody wants to know, because if an eSLOE could be written by one person, but if an eSLOE is written by a group consensus, so this is our PD, APD, CD, and APD, the group consensus, it's a much stronger letter. And almost every rotation that I know of, I don't know of any that don't do this, but they write a group consensus letter. And then the next box, you'll see that what sources of information did you use compiling the SLOE? And these are all the sources of information that we use when we write a group SLOE. Formal written clinical assessments from faculty and then from residents, informal verbal comments from residents and faculty, performance and non-clinical activities like didactics, simulations, and then other non-clinical assessments like final. In our case, we use a final presentation, and then feedback from administrative and our administrative staff, basically. So all of those sources of information are used to fill out your eSLOE. The next section is background information. So this is pretty cut and dry. You'll see that that basically they want to know when your rotation dates are, which is important, especially if you are returning to the match. Whether that's updated or not is a personal, something that has to be addressed personally. And then the grades breakdown and the grading scheme. So you can see here at North Florida, we have honors, high pass, pass, and fail. And 20% of our students last year got honors, 60% got high pass, 20% got pass, and no one failed. And we had 24 students last year, and the grade received by this person was honors. So I wrote this for you guys because everyone's going to be honors, okay? The rotation exam, we have no written exam. We don't give a exam grade, obviously, and we don't show the average exam grade. And you'll see that because mostly when an EM rotation site is your assigned clerkship from your school, they use the shelf exam. So, and you guys are very familiar with that. Our residency does not have, we don't have assigned clerkship students. We have students who are interested in EM that are coming here to rotate to do their audition. And so we don't give the shelf exam. So just let you guys know. All right, part A. So you guys probably, I'm assuming, recognize the terminology fully entrustable, mostly entrustable, and pre-entrustable. So this section is really to look at the student's competency without comparing to other students. Just, are they fully entrustable, which means that they can do it completely independently, mostly entrustable, they need some intervention, and pre-entrustable, ability to perform a focused history and physical exam. Obviously, no student is coming in at the level of an attending or even, I mean, second, third year resident. And so not all the time will you always be completely fully entrustable, but that actually is what medical education is. It's taking people who are pre-entrustable to mostly entrustable to fully entrustable. So there is no shame in the game at not being, if you are deemed not fully entrustable. But these are important for you to know. These are the skills that are going to be directly evaluated. So in my mind, I want you guys, or in your minds, actually, in your minds, I want you guys to think about this and say, okay, I need to demonstrate my ability to perform a focused history and physical exam. If you go through your whole rotation and you never give or take an HPI, for example, you never demonstrate a differential diagnosis, you never formulate a plan, how are they going to be able to even say anything about you on your evaluation? Ability to perform common ED procedures for students, that's going to be laceration repair, abscess, IND, for example. And pretty much like in our shop, we do special procedure shifts where you learn other skills like putting in IVs, putting in, I almost said the wrong word, Foley's, things that you're expected to know, and you should get very good instruction on how to do them. And so we try to focus on that. And you can ask a clerkship what they consider common ED procedures that you should master by the time you leave. The ability to recognize and manage basic emergency situations. Hold pressure, people. No, I'm just kidding. But that is a good skill to have. So these are the skills that you're going to be judged on. I shouldn't say judge. That's really not a great word. Your entrustability is going to be assessed. How about that? All right. Part B. This is rating your personal attributes. Okay. And when I talked about how to crush your rotation, this was one of the things I said was show up early, never be late. And I'm going to tell you, this is where that can ding you. Dependability, responsibility, initiative, and work ethic, punctuality, attendance, and preparation for duty, timeliness and responsiveness in completing administrative tasks. All three of those questions will be negatively affected if you show up late. So you see, so I'm going to read through. So compassion and sensitivity and respect towards patients and team members. Receptibility to feedback and ability to incorporate feedback. This is important and can be the most challenging if you don't get any feedback. So mid-rotation feedback can be very important to you. And this is a big challenge in emergency medicine, because a lot of time in our shop, we do this too. You're assigned to shifts with one, like mostly every single core faculty, and for sure PD and APDs, so that more people can meet you, but then you don't have the longitudinal experience. And so you need to be very proactive about getting feedback for yourself and then showing that you have taken that into account. Dependability, responsibility, initiative, and work ethic, like we said. Punctuality, attendance, and preparation for duty. Timeliness and responsiveness in completing administrative tasks. Very important. If the coordinator of the program tells you to do something, do it. It's like the charge nurse. You must keep the coordinator happy and well loved, as well as the charge nurse. Okay. Interpersonal communication skills with patients and family members. Interpersonal communication skills with faculty, residents, and healthcare professionals. So all of these, and instead of, these aren't activities. So you're not going to have the pre-entrustable, entrustable, mostly or fully entrustable. This is really trying to have a Likert scale for an exceptional EM candidate versus a minimally acceptable, EM candidate. And so you're on a Likert scale, and you are compared to other people that are auditioning for EM. Part C. This is a question that is a norm reference, and basically, how much guidance do you anticipate the candidate will require to become clinically proficient and meet graduation requirements? I actually really like this question because most people will put something and then explain in the comment section, which is next, that some students who come into residency will need moderate guidance, but read what that is. May need slightly more than standard support from time to time, no major issues anticipated. Like, honestly, I need moderate guidance in my life. I think that is completely fine. And this helps discern what kind of needs the student will have. For example, a lot of times people will write, will gravitate towards more of an academic program because of these reasons. And it helps personalize the applicant and let you know if they're going to succeed and thrive in your educational environment. And then the other question is, how highly would you estimate the candidate will reside on your rank list? Top 10%, top 1/3, middle 1/3, lower 1/3, unlikely to be on our rank list. And then they basically will put how you recommended in each category last year. And so we had 2 in the top 10, 5 in the middle, or top 1/3, excuse me, 5 in the middle, and 2 on the lower 1/3. And then Part D, this is where we are allowed to free text and write comments. So this is an example of what you might see. Student X completed his rotation at HCA North Florida Hospital in August 2022, and he was described by faculty and residents as smart, hardworking, and motivated to learn. X's patient presentations, differential diagnosis plans were intern level. Whoops, Andrew. Andrew's medical knowledge was above his peers. X understands emergency medicine, having worked as an ED scribe in the past. And student X will be a no drama emergency medicine resident and will be a fantastic addition to any emergency medicine program. So usually this area will be used to say what characteristics were amazing and noticed to be amazing, what maybe are opportunities for the student, and if there are any blips, like interpersonal skills, maybe he was late once and that might be mentioned there, and then a summary. So that's what is usually on the free text area of a SLOE, sorry. And then the very last part is just institutional information about where you rotated. So someone reading our recommendation can say, oh, our annual census is 100,000 and we're a high acuity patient population. And we go through multiple facilities, and our trauma center designation is at the Hoelle Hospital. And so basically can give you an idea of the environment that the person was doing the rotation in. Okay, so eSLOE FAQs. Let's talk about these because I think these are the questions that you specifically want answered. So the first question to be answered is the recommended number of SLOEs. And I get a lot of questions about this and iterations of the question. So 4 is the number of letters that your ARIS application will allow you to upload. 1 is the number of SLOEs needed to get an interview. And this has drastically changed from basically 2 years ago, but definitely 5 years ago. And COVID was really huge in changing this as well. So in the past, you needed 2 to 3 SLOEs before you even, like at the beginning, as coming out of the gate. And that is not the case anymore. The recommendation is for all programs to assess medical students who have 1 SLOE, and that be fine. So you can see also that I wrote whether it's an eSLOE or a non-residency based SLOE, especially after COVID and rotation guidelines changed. We have now tried to have the non-residency based SLOE be a little bit on more of an equal footing with the eSLOE. And there are some non-residency based rotations that are very experienced educators. And that comes across in how many students they have every year, how they're writing their SLOE, et cetera. And that would be definitely preferable compared to if you are rotating in an ER that you're the first student ever rotating there, and you're basically, they're writing a letter, the first letter they've ever written. That is not going to be very convincing to a program director reading for an application. Important for you guys to know, 0 is the number of changes you can make once you've assigned a letter to a program. So in ARIS, you upload your letters, and then you're applying to North Florida. You assign 4 letters and to North Florida. You cannot change one out. You can't take one away. They're all assigned. You can't make any changes. You can add letters. So if you are doing a late rotation, you're doing 1 rotation in, I don't know, July, and you're doing your second rotation in October or November, then you want to leave space to add your second SLOE. So I just want you guys to be aware of that. 2 is the number of SLOEs preferred by ranking time. And this is up to date with the 2023 core guidelines and what all of the advisors are supposed to be following. And we can talk about that more too, but these are the general guidelines on numbers of SLOEs. All right, what type of letters can I use? So the e-SLOE versus the non-residency based SLOE, we just talked about it, but in summary, the non-residency based SLOE is usually not as well regarded as an e-SLOE. However, there are some non-residency based shops that take lots of students, are amazing educators, and their letters reflect that, and they are highly regarded. Other SLOEs, like the subspecialty SLOE and the off-service SLOEs, are preferred over narrative letters of recommendation. So I will tell you that if you have a subspecialty SLOE, it's not going to be anywhere near as important as the e-SLOE, but the subspecialty SLOE will be better than this was my urology rotation narrative letter. But if you have a very specific, you worked for, I don't know, maybe you have a PhD or you worked in a lab and you devoted your life for 2 years to this thing, and your mentor is willing to write a letter explaining that, and that's a big part of who you are and a big part of your application, then feel free to add that letter. All right. When do you need your letters by? This is another question. So the super cool, perfect happy face is having your letters when programs start reviewing applications. This year, programs are going to drop. Oops, I missed a slash. I apologize. They're going to drop September 27th. It's sometime in September, sometime in September 15th, 27th, whatever it is. This year, it's going to be the 27th. That is when all the applications get dumped. I don't dumped, but we open our program director's work shop, which is what it's called, and I can see all my applications and I can start signing them out. I can start reading through them. I can do whatever I need to do. So if you could have your letters by then basically I can see your whole application. If somebody at that point has 0 letters, then they go into a little bucket of need to review once they get letters. And so you can see that that puts you into the second tier, not of like quality of applicants, but the second tier of which applications I'm reviewing for interviewing. So keep that in mind. So at least 1 SLOE by September 27th, very important. So then the also very happy face, you can add later rotations producing letters, but I suggest to do that before December if you want that letter to help you get interviews. And last year, we saw a ton of late interview offers going out. And so people were getting interviews all the way in November and December because of the way the virtual interview cycle works. So definitely keep that in mind. It is not the same, and some people will talk to you about, that's why I bring it up. But 3-5 years ago, it was like, if you didn't have your whole application in September or whatever, when they dropped, then it was like, good luck ever getting an interview. At this point, it's more rolling. And so I would very much advise you to continually update your application if there are more letters. The last, still happy, but not as happy, is basically if you can add a second letter prior to ranking, it would be nice to have 2 letters over 1, but that does not necessarily, it doesn't sync your application. So I'm sure there might be more questions about this, but this is the general guideline. So how do you get the letters? I think this part is very important. And I think that this can really, it sets apart the students who kind of get it, and then the students who are just kind of going along the current of the river and floating down the river. Letters don't just magically happen. You need to be proactive. You need, especially if you are not in a medical school with an ER attached to your medical school and a residency program attached, like very involved with the e-bank. If you're not that, then you need to be aware of what SLOEs are, which congratulations, all you guys are there, and how to navigate the system. So the first thing is asking where you're rotating, ask all the questions. Do you write SLOEs for students? And if so, what is the process to request one? And then you can ask the questions about that. What can I do to help you write that? Would sending you my CV, because yes, you sent it to VSAS or Clinical Nexus to get the rotation, but what can I do to make it easier for you to write this letter of recommendation? Now you saw what the letter of recommendation was. It's a standard letter of recommendation. So CV is not really going to help me write your letter, but the letter writer and the institution and the coordinator all saw that you were willing to be available and provide whatever they needed. This may be important if you are relying on a non-residency based flow, because you may have to be the person who goes onto the CORD website, looks up the directions, creates an email for your letter writer to make it as easy as possible for them to navigate that system so that you can get that letter. And then this is a kind of a next level situation, but if you are meeting with the person who's going to write your letter, let's say you have a shift with them halfway through your rotation, follow up before they write it. Say, hey, thank you for such a great shift. Do you have any feedback about the shift? I was really working on my presentation. Is there anything I can do that would help you write an even more positive letter for me? And that is not against the rules. It is against the rules to ask what's going to be on the letter. It is against the rules to, well, read the letter, because most, like 90 whatever percent, waive those rights. It is against the rules for them to even tell you what's on that letter. But it's not against the rules to say, how can I improve? Okay. All right. I left a bunch of time for questions because I think there are some special situations out there. I tried to answer any questions that were submitted with your registration. Are there any questions that I can help with out there?
Hello.
Yes.
Hi, thank you. The presentation was really detailed and helpful. I just like to know, so I'm an international medical graduate and I worked in the ER in India. So if I'm asking my in charge over there to write an LOR, would that be an O slow or an NRB slow?
You worked as what?
I worked in the emergency department as a physician. I mean, like after my graduation.
So that would be a narrative, because the OSLO and any of the SLOs are evaluating you as a supervisor in an educational relationship. So you need to have them write a normal letter of recommendation as a colleague, basically, or supervisor for work, but they weren't tasked with teaching you. Am I correct?
Yes, yes. I mean, I was paid, so I think not.
Yep, and that will be valuable information as long as you, so I'm just going to give you some advice about that type of letter of recommendation as well. Having been someone who writes letters of recommendation and have asked for them in the past, when you need to make it easy for them to understand what you would like them to comment on. And so you can actually look at the standard letter of recommendation, look at those attributes that they want to know about in that letter of recommendation. That's what we're looking for in medical students. So writing your supervisor a letter saying, if you feel comfortable commenting on my punctuality, my timeliness, my professionalism, and list all of those things, and then how you performed clinically, that is what I'd want to know. And so if you give them guidance on what you would like them to communicate, that will be helpful.
Okay, thank you so much.
Sure. Anybody else? I know that there were several questions from several people about rotating at a non-residency based program. I will tell you that there are still spots available even in the fall for several programs that I know of. I believe Aventura and our program. I'm gonna stop our recording briefly.